So without any further ado, we'll get started on our first session. Our first speaker is Dr. Sammy Saab. He's a professor of medicine and surgery at UCLA, and he's a tour de force. So he'll get started with viral hepatitis, a new dawn of therapy.
Good morning, everybody. Good morning, everybody. There you go. Make sure we had our morning coffee. So I got 25 minutes to talk about viral hepatitis B and C. That's going to be a challenge. So first of all, I want to thank Eric and Bennett Roth for putting this great symposium together. This is the third year, and I have to tell you, it gets better every single year. And it's great to be here among friends and make some new friends as well. So in the next 25 minutes, we're going to cover two objectives. We're going to review the epidemiology and classification diagnosis of hepatitis B and C, two hepatotropic viruses. And then we're going to talk about selecting appropriate therapy based on these hepatitis C's and based on clinical guidelines. So here's the spectrum of the hepatotropic viruses, right? Hepatotropic viruses. You have A, B, and C. The reason I focus on B and C is, for the most part, these are viruses that are gifts that gifts on giving. You know, once you get infected, you to be infected for the rest of your life. Hepatitis A, you get infected, you go to Tito's Tacos or what have you, you get sick, and you recover. There's no such thing as chronic hepatitis A. Now, hepatitis B has a high likelihood of having symptoms in the beginning with acute infection. Hepatitis C rarely causes symptoms when you get acutely infected. That's why you hardly ever see studies on acute hepatitis C. Just so hard to diagnose. Now, hepatitis B and C have important differences. One is a DNA virus. Hepatitis B is a DNA virus. Hepatitis C is an RNA virus. Hepatitis B, the goal of therapy is to have long-term viral suppression. And we believe this equates with long-term improvement in survival. The goal of hepatitis C, on the other hand, is cure. And the reason I believe there's a difference in the outcomes is that the DNA virus integrates into a cell nucleus. Hepatitis C virus stays in the cytoplasm and remains an easy target for direct-acting agents. Now, this is from a paper published recently in Gut, highlighting that we actually have two definitions of potential cure. So there are some people with hepatitis B, particularly genotype A and D, that you can cure. But there's a functional cure and a complete cure. There are some people with hepatitis B given interferon, oral antiviral medication, genotype A and D. They lose surface antigen, they gain surface antibodies, but there's still cccDNA in the cell nucleus. The only way to tell the difference between a biopsy and doing special stains, and that's not available commercially. So the take-home message is, if you have someone who has acute hepatitis B, one of those rare patients, they still need to be screened for liver cancer on a regular basis, but there's still cccDNA in the cells. You know, when we see acute hepatitis, viral hepatitis, you know, the most common cause is hepatitis A, and the second most common cause, hepatitis B. We still see acute hepatitis B. This is generally seen in the context of people in their 40s and 50s because the U.S. has been vaccinating against hepatitis B among all newborns for the past two and a half decades. So when we see acute hepatitis B, generally someone in the 30s, 40s, and 50 years of age, not someone in their high school or college years. We've had huge progresses in viral hepatitis. This is from a beautiful article from Analog published in Hepatology last year, looking at the advances of 3 decades from hepatitis B. What we understand today is that hepatitis B is a human carcinogen, with the same context as cigarettes for lung cancer. Hepatitis B can cause liver cancer. We had no methods to really prevent hepatitis B 30 years ago. Today we have vaccines that work over 90% of the time. There's improvement in the assays for measuring virus. Before we measure hepatitis B, if you had a viral load of 500,000, it's considered undetectable because the viral assays are very crude. Today we can measure hepatitis B viral levels less than 10 IUs per milliliter. Before we had no drugs for hepatitis B, it was more of a TLC and symptomatic care. Today we have 7 drugs approved for hepatitis B, where they're safe, effective, and tolerable. Liver transplantation was controversial a couple of decades ago. I remember for a period of time, Medicare stopped paying for liver transplant because we have no ways to effectively prevent recurrent hepatitis B in new graft. So it was not uncommon for someone to get liver transplant hepatitis B only to succumb to recurrent infection, graft failure, and death within several years. So we've come a long way in the past 3 decades. I love showing this slide because it reminds us that this concept of immunization has evolved significantly. I remember when I was here a few years ago giving this talk on hepatitis B, China was red. China was red. Hepatitis B prevalence was 8 to 10%. Now China's orange. And that's because our hepatitis B prevalence rates have come down significantly. Mostly in the urban areas, they're still catch up in the rural areas. That's wonderful. I was in South Korea several years ago talking about hepatitis B. And they go, whoa, wait a minute. Hepatitis B, we just don't see anymore. We don't see it because of vaccines and immunizations. We still see it in middle-aged, older people, but not among the youngsters anymore. So this might become a rare disease later in our lifetime. This is also a very exciting slide. It's outdated, but it says here that hepatitis B is a 6th leading indication for transplant, and that's come down substantially. We're no longer seeing the progression of chronic hepatitis B to cirrhosis to liver transplantation. Liver transplant for liver failure for cirrhosis has become a lot less common in the past 10 years. And people have argued this is due to differences in migration patterns, this differences in immunization, difference to access to care. And the overwhelming reason why we think that hepatitis B is becoming less of an indication for transplant is because very effective antiviral therapy. Francis Yao, UCSF, showed us in a landmark article 10 years ago that people were taken off the liver transplant list. The Child-Pugh scores improved, the MEL scores improved with effective antiviral therapy. Unfortunately, transplant for liver cancer related to hepatitis B has remained unchanged. So we're still transplant for liver cancer, a lot less for liver failure for hepatitis B. And when people get liver transplant for hepatitis B, their outcomes today are the best of any outcomes for liver transplantation, the best for any indication, because we can effectively prevent reinfection and recurring disease. These are guidelines put forth several years ago about who to screen for hepatitis B. And basically, you want to screen for individuals who are a higher rate of being infected, patients who are a high rate of being exposed, preventing nosocomial infection, and high risk of medical consequences, particularly those with immunosuppressive therapy. You've seen the slide 1,000 times. I'm sure you all know how to screen for hepatitis B. Simple blood test serves antigen. That's a hallmark of infection. If you see it, for the most part, it's going to be a chronic infection. It's very rare that you're going to see an acute infection in 2015. Even if you don't treat someone with hepatitis B has to be monitored on a regular basis by viral loads and liver enzymes. If someone has a very high viral load, family history of liver cancer, liver cirrhosis, liver failure, they need to be screened for liver cancer, abdominal imaging every 6 months. Most hepatology across the country also recommend doing AFP. That was controversial, but becoming increasingly accepted in clinical practice today. And the new liver site guidelines will probably reintroduce AFP as a screening modality for liver cancer. So if you don't treat someone, you need to screen them for liver cancer if they're at risk of having tumors. Very also important that when you have someone with hepatitis B, the next most important question about, after you talk about their family and their complications, is asking about their siblings, their spouses. Have they been screened for hepatitis B? We had a patient we saw at UCLA for liver transplantation in their late 50s, early 60s, who came in with liver cancer, hepatitis B, and our distinguished fellow asked them, well, has your spouse been checked for hepatitis B? Have your siblings? Never. So our fellow picked that up and was able to indirectly make a diagnosis of hepatitis B in the family members and help them start antiviral therapy. Not everyone with hepatitis B progresses to chronic disease, to cirrhosis, liver cancer, liver failure. There are a number of risk factors have been identified, and a number of studies have been reviewed here by article by Yim and Log. But basically, the longer you're infected, there are higher chances of having fibrosis and liver complication. Men always do worse with women than women, right? For everything, including hepatitis B and hepatitis C. High levels of viral replication are also a marker of poor outcome. High markers of viral replication have been associated with developing liver cancer, cirrhosis, and liver failure. So when we see a patient with hepatitis B, we look at both the liver enzymes and the viral level. Liver enzymes are a pretty good surrogate marker of damage today. Viral levels are good predictors of problems of the future, like cirrhosis, liver failure, and liver cancer. Now, treatment guidelines today revolve around the viral level and liver enzymes. Both have to be elevated to be considered for antiviral therapy, but there are exceptions from people who have a family history of liver cancer or cirrhosis, or people who are embarking on immunosuppressive therapy. These are guidelines for treating hepatitis B. They're pretty old now. They're about 8 years, but they still resonate true today. And the goal of therapy is to achieve viral suppression. Unlike hepatitis C, where the goal is to cure the viral infection. We have a number of drugs that have been approved. The two frontline drugs are entecavir and tenofovir. These drugs are very potent, and the risk of resistance is pretty much close to nil in naive patients, close to nil. What's wonderful is that we were all trained that cirrhosis was a final common pathway. And once you develop cirrhosis, it was an irreversible situation. Now we understand that with effective antiviral therapy, with viral suppression, that you get cirrhosis regression. So reverse liver damage. And the reason I bring this up is that, we started someone on therapy, you're going to commit them for pretty much a long time of treatment. So one of our goals, one of our objectives is to improve adherence and compliance. How do we do that with a disease that's got no side effects for the most part, no complication, no symptoms, and a drug that's very safe and tolerable? How do they keep someone motivated to continue taking their entecavir or tenofovir? So we come back to these studies showing that with effective viral suppression, you get reversal liver damage. And patients like to hear that there is long-term improvement. That was true with tenofovir. Similar studies have shown improvement of fibrosis scores with hepatitis B. Now, this is from a paper that was published this year, fresh off the press, and looking at hepatitis B reactivation risk. Dr. Akabani, my colleague, had a discussion at one of the fellow conferences, and a very important question by Bennett Roth, asking about subset individuals who will benefit and what is the risk of reactivation. So in this paper by Raj Reddy from University of Pennsylvania, looking at stratifying patients' risk of reactivation with their serological status and their treatment. Who are the patients that may benefit from viral suppression. Most studies have utilized lamivudine for patients. I think in our conference about Akabani and Dr. Roth had very important input, suggested maybe we should probably focus on more effective antiviral therapy that have got really no risk of developing resistance. So although most studies are using lamivudine, I think most in clinical practice are preferring entecavir or tenofovir. Now, what is the risk of dying if you do get reactivated? It's over 40%. Over 40%. And what's a little alarming is even the patients who have surface antigen negative or core antibody positive, in the right setting, with chemotherapy, there still may be a risk of reactivation and even potentially death. So we see a consult every 4 to 6 months of someone who received chemotherapy and is in a state of reactivation. So once someone reactivates, you got to act really quickly because the consequences are potentially deadly. So when someone reactivates, off-label, we do is combination antiviral therapy. We have no data for this, but because these two drugs are non-overlapping in terms of mechanism, and they're both very safe, effective, we think it's an appropriate course on who already reactivates. Another very important topic is vertical transmission. We cannot go to a hepatitis B meeting or advisory board consulting meeting without this being discussed. There's some people who are pregnant with hepatitis B, and the question is, who do you treat? For hepatitis B, with a pregnant woman, you put on therapy, because the concern is that the baby's born with a funny eyebrow, they're gonna blame you if you put them on drug. So we're very selective. We have 2 lives at stake, not just one, the mom and the baby. So guidelines have said that we should treat pregnant women only the viral load. It's very, very high. In this article by Pan and colleagues, they highlighted that a viral level over 200,000 IUs, which are 1 million copies, should be the threshold to start antiviral therapy, or in someone a mom who already transmitted hepatitis B to a baby with a lower viral level. But generally, the cutoff in a woman is 200,000 IUs. We prefer to start antiviral therapy the 3rd trimester, and the only hepatitis B drug that's category B is tenofovir. So the reason why 200,000 was chosen is it appears that above this level, viral level in a mom, that the vaccine and immunoglobulin does not work in the infant that well. So the vaccines are effective 90% of infants. The 10% breakthrough is a result of the mom's viral level being high, over 200,000 IUs. Now I gotta tell you guys, in the past 15 years I've been practicing at UCLA, I treated 1 woman with a viral load over 200,000. Hepatitis B, like any other liver condition or GI condition, it becomes quiescent during the 3rd trimester or during pregnancy. So fortunately, we haven't treated many patients. This is a very, very busy slide, and the reason I'm bringing up, this is from a fresh article, 2015, the reason why I show this slide, and it's meant to be busy on purpose, is to show that we're in a new era of hepatitis B, that we believe the next 4 to 5 years, we're gonna have cures for hepatitis B, where we don't get only a functional cure, we'll get a complete cure of viral infection. So when we have patients on hepatitis B therapy, people we're following, we keep a modem and saying that there's going to be a new drug coming out, new drugs coming out in the next few years that could potentially eradicate your virus. Now we're going to focus on hepatitis C, very exciting area. We're in the midst of a revolution. And one of the challenges for us in hepatology is how to keep up with all this new data. And I have to apologize already, I have to apologize right now, that this slide that was made 2 weeks ago, it's already outdated. There's some great literature by the classifier that recently been presented and is not on the slide deck, unfortunately. Hepatitis C, remember there are 6 hepatitis C families, 6 genotypes, and the clinical implication, it dictates what treatment regimen you use for your patients. You've seen the slide 1,000 times showing that hepatitis C goes through this natural history where substance individuals go on to chronic liver disease. The sexy thing for us hepatology is discussing extrahepatic manifestations. We're having increasing burden of liver disease today in society, where today 15 to 25% of patients with hepatitis C have cirrhosis. And we believe this burden will be even higher in the next decade. We believe 40% may have cirrhosis. I remember when I was in training 15, 20 years ago in San Diego, we rarely saw a patient on medical service cirrhosis, rarely with hepatitis C. Today, UEC has a paper published that in the past 3 years, the number of discharges related to hepatitis C has over doubled. So we're realizing this increasing burden to society of hepatitis C as a reflection of the cohort that got infected back in the 60s and 70s, now seeking medical care. Hepatitis C goes without saying that it's the most common reason for liver transplantation. Around 40% of all transplant for hepatitis B, 40%. Hepatitis C, it affects people's survival. What's wonderful, reassuring is we have good data show that curing hepatitis C leads to improvement in survival. Now, I can only say that for people with advanced disease, stage 3 and stage 4. I can't sit up here talking to you about stage 0, 1, 2 have the same impact on survival. We just don't have that data. And people with mild disease get to a car accident tomorrow and die. And they may never get to the point of advanced disease. This reminds us about the economic burden. Taking care of someone who's got mild disease is very different from someone who has more advanced liver problems. The cost of RFA, it's in the tens of thousands of dollars. A chemomodulization could be $50,000. Y90, Yttrium 90 could be $80,000. And a liver transplantation, God only knows what that would cost. This is a very important study by Dr. Lee and her colleagues at Taiwan showing that hepatitis C is a systemic disease. Not only does it affect the liver, and you see here people dying from liver cancer, but people also have extrahepatic manifestation. Mostly lymphoma, cryoglobulinemia, kidney failure. And we're seeing this today in our clinical practice. I love telling a story about a woman I saw a couple months ago with cirrhosis and hepatitis C, and she wanted to be treated for hepatitis C, the new hepatitis C drugs, but she was a little too sick for me to start drugs. She had ascites and had some decompensation. And I go, listen, I don't think we should treat right now. Talk about liver transplant, and we could talk about therapy after transplantation. And as I walk out of the room, she goes, wait a minute, I got a cut in my ankle. I go, cut in your ankle? I'm not a skin doctor. Okay, I'll look at it. So I look at it, and goes, you saw the white tendon of her ankle. I thought I was on a set of The Walking Dead. It was so horrible. This lady has symptomatic cryoglobulinemia causing severe vasculitis. That's a medical urgency because cryoglobulinemia causes end organ damage. Not only vasculitis, neuropathy, retinal problems, and nephrotic syndrome as well. So the screening strategy for hepatitis C has failed miserably. How many people want to disclose to a doctor, right, that I used drugs when I was in high school or college, or I used cocaine? And do most of our patients who are elderly remember they got a transfusion? No, because we didn't send people back in the 50s for transfusions. So the idea of screening hepatitis C based on risk factors failed miserably. So now develop additional criteria for screening, and that's based on age. So if you're a baby boomer, the CDC recommends being screened at least once in your life, because 70%, 70 of all hepatitis C is found among baby boomers. Cost-effective studies have demonstrated that it makes sense to screen individuals for a chronic hepatitis C infection. What we've learned of the past decade, it's a mechanism of how hepatitis C infects the liver cell and how it replicates. The reason I bring this up is this now serves as information to cure hepatitis C as targets for therapy. When you have someone with hepatitis C, you have to assess the disease severity. It's right now for hepatitis C, it's so easy to treat. It could be simple tablets without interfering with minimum adverse effects. But that should not take away from underlying the disease severity. It's important because someone has bridging fibrosis or cirrhosis. They're going to be at risk for liver cancer even if you cure the hepatitis C infection. And you can stage them any way you want to. Biopsies, serum biomarkers, elastography. Imaging, ultrasound, CT, or MRIs. Because advanced disease, if you cure them, they're at risk for liver cancer. I can't tell how many patients, Dr. Durazo, Dr. Kobani, and I've seen who people have been cured of hepatitis C want to come back several years later with liver tumors. Here's a study looking at FibroScan, elastography, how it predicts fibrosis. And this is becoming the gold standard in the United States in terms of predicting fibrosis. Non-invasive, very quick, done in the office. The issue is machines are very expensive, so access to these machines are still extremely limited. For hepatitis C, we have a number of direct-acting agents. We have 3 broad categories. And the reason I bring it up is because we treat hepatitis C with combination of these drugs. For instance, we might use imipivir and sofosbuvir. We might use for the avid combination all 3 of the direct-acting agents. Or for Gilead regimen, we might use only sofosbuvir and ladapivir. So you don't treat these disease, hepatitis C, with a single agent, using combination of direct-acting agents. And the cure rates are astonishing. So when I see a patient in the office, it's not, can we cure them? We can cure anybody right now. Look at this. If you don't see a 9 in front of the cure rates, we're not using that drug. I was here last year talking about cure rates like 80, 90, 80%, 70%. When I was here 3 years ago, it was 70%. Look, that's over 90% cure rates. It's amazing. It's amazing. So the challenge is not who you treat, it's who don't you treat. So people who don't treat, people who have decompensated liver disease, ascites. Because I'm not convinced, nor most hepatologists, that even cure hepatitis C and someone's got decompensated liver disease by ascites, we're going to make a difference in survival. We had a patient not too long ago that we cured of cirrhosis with sulfosylmipir. 5 months later, admitted to UCLA, dies of sepsis. So do we make a difference in this guy's life? We had another patient with HBV hepatitis C co-infection with cirrhosis, advanced disease. Also cured him, died of varicose bleed. So we got to be selective. The other group of individuals that we don't have a lot of data on are dialysis patients. And we hope in the next few meetings from the liver societies and congresses, we'll have more data on this. Genotype 2, the data is very, very good. It's an approved regimen of ribavirin. For a cirrhotic experienced patient, we're trying to get pushed for 16 weeks off-label. 16 weeks off-label. Genotype 3 is probably the most frustrating, and I'm sure you'll have patients that you treated with sulfosylmipir and ribavirin, expecting high cure rates, and they failed. They failed. So the first row here is an FDA-approved regimen, but in our practice, if someone is treatment experienced and cirrhotic, we're trying to approve for at least 12 weeks of sulfosylmipir and ribavirin. And yes, we are getting these approved through insurance company. This is a regimen approved by the European Society, but not the FDA. There are so many patients who, am I over time, Ben? 2 minutes, okay. I gotta speak faster. No, don't get worried, Dad. All right, Dad's getting, oh God. All right, so there are so many patients with hepatitis C. The Liver Society thought they're doing us a favor. And they actually did the opposite. They actually hurt our patients. The Liver Society has said that we should prioritize patient based on the need for therapy. And then we should prioritize patient for therapy. The top one in people who have advanced disease. People who had a liver transplant. People who have extrahepatic manifestation as a highest priority. High priority, co-infected, fatty liver, comorbid conditions. The problem is insurance companies have taken this and only approving people with highest priority for the most part. So they've done our patients a harm. And we have patients who have stage 2 disease and they go, I don't get it. I took care of myself, I lost weight, I stopped smoking, I stopped drinking. And now you're saying I'm getting punished? So on the other hand, the past 2 or 3 weeks, we've seen a dramatic change in insurance companies approved for therapy. So these barriers to therapy are being overcome for most patients. Last Thursday, we had a patient with stage 1 approved for antiviral therapy. I'm a cup half full person, but I got to tell you, most of the data that we have showing improvement in survival in patients with cirrhosis is based on interferon therapy. But guess what? Those patients tend to be a little healthier with platelet counts 110 or 20,000. And I would challenge people treating these antiviral therapies and these advanced cirrhotic patients where we're treating people with platelet counts to 50,000, 60,000. I don't think we're going to reap the same benefits in terms of reducing risk of liver cancer, cirrhosis regression, or liver cancer recurrence. So be careful about overestimating the benefits of therapy. See, my theory is that someone who has where you saw reduction in liver cancer with cirrhosis and hepatitis C, they have platelet counts 110 to 120,000. Otherwise, they couldn't take interferon. Well, guess what? In someone who's got platelet counts that high, there is a rate of regression cirrhosis. So reduction in the rate of liver cancer was probably to some degree regression of cirrhosis. When someone's got a platelet count of 50, 80,000, you ain't going to regress cirrhosis. You ain't. It ain't going to happen. So I love to show this slide, and it shows hepatitis C is going to join a club of rare diseases. And in an ideal condition, we treat the majority of patients. Hepatitis C could become a rare disease in our lifetime. In our lifetime. Now, people say the liver means, you'll be out of a job. No, we've got fatty liver, right, Simon? Yeah. And so many people who have advanced disease are still going to require current therapy. All right. So in conclusion, so the goals of therapy between hepatitis B and C are pretty dramatic. Hepatitis B, we're looking at long-term viral suppression, and we believe that leads to improvement in quality of life and survival, potentially regression in early cases of cirrhosis. Hepatitis C, the goal is cure. And you can cure hepatitis C with pills between 8 and 24 weeks. Now, how many conditions can you cure with a pill? Hypertension, diabetes? No. And both hepatitis B and C could become rare diseases. Hepatitis B, I would argue, through prevention, like immunization and vaccine, and hepatitis C through antiviral therapy. All right, well, thank you for your attention and participation.